So welcome. My name is Bessie Bitzes. I'm one of the co-chairs for the research forums with David Rice. So this is our second research forum of the Congress. And for those of you who don't know, the research forums really are a legacy of Dr. Robin Cohen, who really wanted to carve a space out at the Congress that was very specifically for research. So we are so happy to continue on in that tradition. And the way that we prepare the research forums is that through the abstracts that are submitted for the Congress, we select the ones that we think would offer a lot of reflection and discussion for the day, and we try to group them together. So this morning we have 3 research articles that will be presented that have something to do with technology in palliative care, which is really exciting. There actually isn't a question-answer period during the research forum, but what we do have is Dr. Murtagh, who will provide a reflection and a discussion after the 3 presentations. So we have 2 of our presenters here today. I'm going to introduce them, and when our 3rd presenter arrives, I'm just going to run back up and introduce her. So, to begin, we have Monisha Kabir. Monisha completed her Master of Science in Health Systems at the Telfer School of Management, University of Ottawa, and has completed her Honours of Bachelor in Science in Biology at the same university. Her research interests involve exploring the experiences and sense-making of patients receiving inpatient specialist palliative care and their family caregivers, including during the COVID-19 pandemic. For the past 11 years, Monisha has been employed in various positions in healthcare and research with the Department of Family Medicine at the University of Ottawa, the Bruyere Research Institute, Cochrane Bias Methods Group, Health Canada, and a family medicine clinic. And her presentation is called Wow, It Feels Like I'm Outside, a novel interactive virtual travel and reminiscence technology life view for adults in palliative and end-of-life care settings. Our second presenter is Dr. Chin-Yee. Dr. Chin-Yee is a palliative care physician at St. Michael's Hospital, Toronto. His postgraduate medical training was in internal medicine and palliative medicine at University of Ottawa. He also completed a Master of Science in Clinical Epidemiology at the Institute of Health Policy, Management and Evaluation, University of Toronto. Dr. Chin-Yee is interested in understanding the role of various medical therapies and interventions in improving symptoms and quality of life in medically complex patients with advanced illness, with a focus on hematology topics in palliative care. His specific interests include transfusion, thromboembolic disease, and anticoagulation, and his presentation is entitled Red Blood Cell Transfusion and Associated Outcomes in Patients Referred for Palliative Care, a retrospective cohort study. Oh, please join us if that's okay. Take a minute, it's okay. Thank you. So, coming up to the table is Bella Vivat. Thank you. So Bella is currently Principal Research Fellow in the Marie Curie Palliative Care Research Department at University College London. Her central research interests are spiritual care and well-being at the end of life, along with the experiences of people living with chronic and/or life-limiting illnesses, and the social construction of knowledge. She has worked in 5 different research organizations on a broad range of collaborative, qualitative, or mixed method studies, including developing PROM tools and exploring people's experiences living with chronic fatigue, arthritis, advanced multiple sclerosis, liver disease, and with sedative medication and palliative chemotherapy. She began her research career with an ethnographic study in spiritual care in a Scottish hospice for her PhD at the University of Edinburgh, awarded in 2004, and she is the co-chair of the EAPC Spiritual Care Reference Group. And finally, we have our discussant, Dr. Fliss Murtagh, who many of you, I hope, had the pleasure of listening to during our opening plenary. Dr. Murtagh is qualified in medicine in the UK since 1986. She worked in general practice for almost 10 years and then undertook specialist training in palliative medicine. She worked at the Cicely Saunders Institute, King's College London from 2002 to 2017, where she completed her PhD, became clinical senior lecturer, and then reader in palliative medicine. She is now a professor of palliative care at Hull York Medical School and visiting professor of palliative care at the Cicely Saunders Institute, King's College, London, UK. Thank you, all of you, for being here with us, and we look forward to the discussion.
Okay, hello everybody. My name is Monisha. I am a research associate with the Breer Research Institute and also with the Department of Family Medicine at the University of Ottawa. This work I'm presenting on today is with the palliative care team at the Breer Research Institute. And it's on a novel interactive virtual travel and reminiscence technology called LifeView. For adults in palliative and end-of-life care settings. And that quote, "Wow, it feels like I'm outside," is actually taken from a patient who participated in our study that hadn't been outside for several months, just due to her condition. So that was kind of nice that she had that reaction. So I don't have an affiliation, financial or otherwise, with a for-profit or not-for-profit organization. The technology that we used for the study was provided in kind by Murtagh, which is a Norwegian technology company. We actually approached Murtagh to use the technology, and the study is funded by the Breer Academic Medical Organization Innovation Fund. So at the conclusion of this presentation, participants will be able to evaluate the impacts of using a novel virtual travel and reminiscence technology on the physical and psychological well-being and quality of life of adults receiving palliative and end-of-life care. So I didn't take time to fully familiarize myself with the CanMed's competency framework, but I feel that this presentation will address the scholar and health advocate attributes. So I'm presenting today on behalf of quite a large research team full of interprofessional providers as well as researchers. Dr. Shirley Bush is out there in the audience there, and the study co-PIs are Rebecca Hackbush and Dr. Jill Rice, and we have people from palliative care as well as long-term care settings involved. So we know that psychosocial and existential suffering is common in patients receiving palliative and end-of-life care, and this is linked to loneliness, depression, desires for hastened death, hopelessness, suicidal tendencies, and decreased quality of life. And there's lots of research to support psychosocial interventions to improve quality of life and improve emotional distress and existential distress. However, there was also a recent systematic review and meta-analysis to show that brief sessions can still improve quality of life as well as decrease emotional and existential distress. And they were looking at brief interventions, so that those that were less than 4 sessions or less than 21 days. And they found that these still had an effect. So their recommendation was that these should be made available to terminally ill patients. So now to the technology. So this is what it actually looks like. It's a prototype software in that we're actually using one component of a technology that already exists. So it's called ModiView. You can actually Google that if you'd like, or you can just Google the company name and it'll come up. And it's paired with a laptop tablet, a touchscreen laptop tablet, where it allows patients and residents to actually access over 1,600 different videos in over 40 different countries. And each of the videos kind of feel like you're walking down whatever path or road in the destination that you choose. And it allows patients or residents to travel to places that they might have wanted to visit but haven't been able to make it to, or they've already visited and they want to revisit to remember some memories or things like that. And the company's original goal, was to support quality of life of older adults. So they actually used this audiovisual input paired with a bicycle. So it was pedaled by both the arms as well as the legs. But I think we all know that in a palliative and end-of-life care context, it's not possible to use that in most cases. So we just ended up using the audiovisual input just because most of the patients that patients and residents we were visiting were bedbound. And so this current pairing is actually a new vertical for the technology company as well. So they're kind of they're eagerly anticipating what our results will be at the end of the study. And we're also using just a TV and laptop setup versus virtual reality headset. So I wanted to briefly explain our rationale for that. So first is that it increases interactivity. So family caregivers, whether that's actual family members or friends or neighbors, can actually participate with patients and residents, and so it allows for them to share memories or visit somewhere new without being in isolation and just listening to it themselves. And it also, just in the palliative and end-of-life care context, disorientation, nausea, confusion, delirium, all these things are very common. So, and VR headsets might actually increase the possibility of that. So using something like a TV and a laptop decreases the possibility of that, and if people end up having any discomfort, we can stop immediately as well. And the other thing is that it makes it more accessible. So VR headsets can be quite expensive, and not everybody's going to be able to afford it. So this allows us to kind of make sure that this is available to anybody after the study is done as well. So for our primary outcomes, we were looking at physical and psychological well-being as measured by the Edmonton Symptom Assessment System. And our secondary outcomes are change of quality of life, as measured by the McGill Quality of Life Questionnaire, which incidentally Robin Cohen and her team created. So it's kind of fitting that we're presenting at that I'm presenting at a research forum today. And also change in physiological well-being measured by heart rate and blood pressure, and psychosocial and quality of life effects using semi-structured interviews and field notes. So for our methods, we're using a concurrent triangulation mixed methods and pre and post design. So this means that we've got both a quantitative and a qualitative arm, and we're triangulating these results. So for the analysis, for the quantitative arm, we're using descriptive statistics and analysis for paired data. And for the qualitative arm, we're using an iterative thematic analysis approach. Our goal sample size is 92 participants. And our study settings are the Inpatient Specialist Palliative Care Unit at the Elizabeth Breer Hospital in Ottawa, Canada, in the community using the Champlain Regional Palliative Consultation Team, and also the Breer Long-Term Care Residences in Ottawa again. So since October 2019, we've had 83 patients and residents that have been approached to participate, but of course, we know that it's quite challenging to conduct research in palliative care. And then on top of that, we had ongoing research restrictions due to COVID. So we were actually shut down for a full year initially, and then on and off over the following couple of months. So we've only had 36 participants participate fully, so whether or not we reach that target of 92 participants is kind of a little out there, we'll see. Our mean session duration is 60.9 minutes, so people are actually watching it for quite long. And our preliminary qualitative thematic analysis has yielded 4 key themes so far. So the first being reminiscence, which we kind of anticipated. Participant satisfaction with video and location availability, perceived benefits of participations, which included feeling relieved of boredom, having an escape from their current situation or surroundings, and also just being able to do something else and kind of keep themselves busy. And suggestions for improvement and barriers to participation were also discussed. So with respect to the future directions of this project, we don't want to conduct a research study and then, completely shut down and not allow people to use the technology anymore. So part of what we've built into the research study is allowing volunteers to actually, specially trained palliative care volunteers, to deliver the technology to patients after they've already participated in the research study. And then once the research study is also done, we would like to be able to continue integrating the technology into care practices using volunteers, both on the palliative care unit, hopefully one day in the community, and on our Breer long-term care residences. So our preliminary data suggests that there are positive impacts of using LifeView in palliative and end-of-life care, and it also provides support for implementation of similar technologies in inpatient and community palliative care and long-term care settings. So I've just got my references there in case anybody's interested in those. Thank you for listening. If you do have any questions, feel free to email me instead since there's no question period today.
Hello, everyone. Thanks for including me in the program today. My name's Nick. I'm a palliative care physician in Toronto at St. Michael's Hospital. But a lot of what I'm going to be presenting today actually was stuff that I began and completed during my residency training in Ottawa. It's part of the work we've done on red blood cell transfusion in palliative care. I have no conflicts of interest to declare. The learning objectives for this talk are, at the conclusion of this talk, participants will be able to recognize some of the baseline characteristics associated with red cell transfusion, as well as the outcomes associated with transfusion in the palliative care setting. These are the CanMed's roles that we'll be covering today. So with respect to the study team, it was a combination of individuals from the University of Ottawa, where I did my residency training, as well as some of the analysts at ICES, which were very helpful in getting this all the data collected and analyzed. And this was published just last year this is one of the parts of our research is published last year in the journal Transfusion. So just a bit of background on the topic itself. Fatigue and shortness of breath are quite common among patients receiving palliative and end-of-life care, and they are known to impact quality of life in these patients. Often there are many reasons they can be short of breath, but anemia can certainly be a contributor. And while red cell transfusion is a potential therapy for symptoms of anemia, its effectiveness and safety in palliative care populations is not well understood. And also there are many other factors that can influence this decision to transfuse. There's a bit of literature on this, part of it conducted by our group, and we initially conducted a systematic review. What we know from the reviews and observational studies on this topic is that there's a lot of variability in transfusion practices, and the types of studies and population studies also vary quite a bit. There's been mixed result with respect to symptomatic benefit and the risks of transfusion in palliative care patients. But overall, I think that it highlights that there's a lack of high-quality evidence to guide transfusion practices in palliative care. Part of what we did in the initial steps was conduct a survey of palliative care physicians in Ontario, and what we found is that frequently red cell transfusions were being prescribed to patients under their care. They were often prescribing transfusions themselves, but also reluctant to stop transfusions in patients who are already receiving them. And as some of the factors that were noted as to be influential in this decision to transfuse, reported symptoms, bleeding, but also things like pressure from patients and families. And so altogether, we kind of came to the conclusion that the decision to transfuse red cells was complex, and we needed to study this more and understand some of the risks and benefits and real-world practices. So we designed a study where we looked at inpatients with cancer and non-cancer terminal illnesses receiving inpatient palliative care. We aimed to describe the incidence and episodes of red cell transfusion, to identify some of the demographic and clinical features associated with transfusion, and also to take an exploratory look at some of the downstream outcomes, specifically overall survival and location of death. So with respect to study design, there's a lot in methodology here because we did a lot of things. I'll try and keep this as brief as possible. It was a retrospective population-based observational cohort study of only adults, and to be included, you had to have received an inpatient supportive and palliative care consultation at the Ottawa Hospital, which is a large academic center, between 2014 and 2018. We collected data on sociodemographic and clinical features, and data was linked through to a number of different data sets were linked: an internal palliative care data set, provincial health data at ICES, as well as the Ottawa Hospital has a transfusion data warehouse. So we studied red cell transfusion as the primary exposure, and before I say that, I will also say that we did want to also look at some of the predictive factors for transfusion itself. So we did look to it as an kind of an outcome as well initially. But if we had to define the exposure, it would be for any patient who received at least one red cell transfusion occurring at least one day after the initial inpatient palliative care consult. That was the transfusion group. The downstream outcomes we looked at were overall survival, and we used different time points as the index, but we looked from the initial consult, also from the time of the first transfusion after that consult. And then we also looked at location of death, so whether the patient died in an acute care hospital or at home or another type of setting. In terms of analyses, first we looked at predictive factors for transfusion after palliative care consultation itself, and in the box on the right there you can see some of the demographic and clinical factors we studied. Then to where transfusion was the exposure, we looked at overall survival, plotting survival curves and running certain Cox proportional hazards model comparing groups by primary palliative diagnosis. And we used a multivariable logistic regression to look at individuals for location of death. So in total, we identified 6,980 patients who received an inpatient consult from 2014 through 2018. Among these patients, 12.7% of them had received at least one transfusion episode following this palliative care consult, so a significant portion. And you can see this table just shows some of the basic features of the overall cohort. Mean age 73 years old, about evenly split between both sexes, and a fairly high prevalence of comorbidities and a poor functional status as well. So of the total cohort of nearly 7,000 individuals, as you can see, these circles are meant to kind of show some of the numbers, but over 2,000, or close to 30% of them, had a prior transfusion, and 12.7%, like I said, had received at least one transfusion after the initial palliative care consult. Interestingly, for 372 individuals, or about 5% of the cohort, this was the actual first transfusion that was documented. It occurred after the palliative care consult. Of those who received consults after palliative care involvement, they received a median of 2 units over 2 transfusion episodes. The risk of the adverse outcomes were reported in 4.2% of patients, and the median pre-transfusion hemoglobin was 75. Nearly a quarter had a PPS of 30% or less, so bed-bound functional status, and the median survival from death occurred from the last transfusion of 24 days. So at the beginning, the first kind of question we asked is, what were the factors associated with receipt of transfusion? So we ran a multivariable logistic regression model looking at all those variables I was showing you. And some of these may surprise you, some of them probably not. So some of the factors associated with red cell transfusion were being younger, higher income, having a diagnosis of a hematologic malignancy, odds ratio of nearly 3 compared to those with non-cancer diagnoses. Also, those with solid organ tumors versus non-cancer diagnoses were more likely to be transfused. And probably not surprising, lower hemoglobin and prior transfusion were both predictors. You were less likely to be transfused if you had a poor performance status, or if you had a pre-existing do not resuscitate documented at the time of the palliative care consultation versus those who were to be full resuscitation. Okay, so now I'm going to speak to the downstream outcomes. Before I start showing you survival curves, I want to just remind you that there is a lot of the definitions we used for the exposure of red cell transfusion here, because I don't want you to start interpreting causality necessarily from this as a red cell transfusion as the intervention. because there is a lot of potential for bias. And I will speak to that briefly if I have a moment, but essentially the transfusion group were those who received at least one transfusion any time after that initial palliative care consultation. As you can imagine, this introduces some immortal time bias. So think of it as the group that either received or would receive a transfusion rather than those who transfused and necessarily the downstream outcome happened afterwards. But this is the overall cohort. So of all patients, the green line is those who received a transfusion, and the red line are those who did not receive a transfusion after palliative care consultation. The median survival of the entire cohort was 19 days. Those who would receive a transfusion, the median survival was 83 days. Those who weren't, 15 days. I think it's interesting when we break it down, these same survival occurs, but we break it down by primary diagnosis, a palliative diagnosis. And here's where we see some divergence in the even more differences. So as you can see, if you compare the solid organ tumor and the hematologic malignancy patients, the transfusion and no transfusion curves are much closer together than those with the non-cancer diagnoses. So this may speak to who they were choosing to transfuse among these patients, but they were and clearly transfusing sicker solid organ tumor and hematologic malignancy patients. Now this curve is slightly different, and so this is the survival that are after the first transfusion. So it includes only individuals who received a transfusion after the consult, and I broke it down by primary palliative diagnosis category. So what we see here is that of those who receive a transfusion after the consult, the median survival was 56 days after that first transfusion. Of those with a solid organ tumor, that survival was 51 days on average, and they had the poorest survival compared to the other groups. And when we ran this in a Cox proportional hazards model, the hazard ratio was 1.7 versus non-cancer diagnoses for those with solid organ tumors. So it's interesting to look at different disease classification and survival after transfusion. Finally, location of death. So using a multivariable logistic regression model, we looked at the likelihood of dying in acute care versus elsewhere. And obviously this analysis only included those who died during the study period. But also we had an important exclusion here. We had to exclude those who died very early, essentially those who that probably were so sick they probably would never have been transfused, or would not be so sick that we didn't anticipate survival to discharge and potential benefit from transfusion. So this was a methodologic call we had to make. So receipt of transfusion in these individuals was independently associated with a higher risk of death in acute care with an odds ratio of 2.15. So just a few discussion points now. So as we saw among inpatients receiving palliative care, red cell transfusion was common, and it frequently occurred in the final month of life. We saw we delineated some of the factors associated with receipt of transfusion. Those with cancer diagnoses, specific hematologic malignancy, would be consistent with the existing literature on this topic, as well as some obvious factors that you would expect, lower hemoglobin, younger age, to be associated with that. We found that transfusion following palliative care involvement was associated with greater overall survival, but again, based on the study design, I think this is likely a reflection of the cohort transfused rather than a result of transfusion. And we saw that survival differences between the transfused and non-transfused patients were more pronounced in the non-cancer patients versus, especially compared to hematologic malignancy and solid organ tumor. But this begs the question of whether clinicians are more likely to transfuse patients with hematologic malignancy regardless of the severity of their illness. But it would be in keeping also with the fact that bone marrow failure is an early manifestation often of hematologic malignancy. We also saw that survival following that first transfusion was quite poor overall, and especially in solid organ tumor patients. And furthermore, a substantial minority of these patients were of poor performance status and bedbound status. And there have been several other articles that have been published that discuss whether transfusion is truly beneficial or appropriate in such a setting. And among individuals who are surviving at least 30 days from the initial palliative care consult, the group that we could foresee having potential benefit from transfusion, transfusion was actually associated with a twofold increase in likelihood of dying in hospital. And while the location of death is a known patient-important outcome, I think this association clearly requires further study, and I'm not trying to infer causality from this. And just finally, a brief point on limitations. Yeah, obviously, interpretation of many of our results, specifically survival, though, is limited by immortal time bias and confounding by indication. So, in other words, if you survive longer, you're more likely to get transfused. If you look sicker, you're probably less likely to be prescribed a transfusion. And finally, I think an important thing that I always get asked is the big data we looked at did not capture the symptoms following transfusion episodes. It was more a big picture look, and it's something that we are certainly interested in exploring further. So in conclusion, our findings raise cause for further caution and considerations of the risks and benefits when prescribing transfusion therapy in the palliative care setting. And it hopefully shows the importance of the need for future studies assessing the risks and benefits of transfusion in this group, with the goal of developing patient-centered guidance on this, but also ensuring judicious and safe use of blood products. So I wanted to thank the study team, many of my mentors in Ottawa, and research collaborators at ICES, my supporters, my friends and family, and a special thank you to and tribute to the late Dr. Eliana Seidenberg, who was a hematologist and mentor of mine, who actually got me started on this topic. So happy to take your questions by email or however afterwards. Thanks.
Okay. Thank you all. Apologies if I'm a little bit distracted. You may know I'm from UCL in London in the UK, and you may know there's fresh chaos at the moment in the UK. So it's all a bit, everything is kicking off over there, so it's kind of strange I'm here. Anyway, but I'm going to try and talk to you about visible technology in palliative care, and from a big data study to a very small, very focused qualitative study. This was accepted for the conference that was due to be held in October 2020, and then rolled over to the conference that might have been held last year, and then rolled over to this one. But we think the data are still relevant, even if they're a little bit old now. I don't have any affiliations to declare. Learning objectives, I hope you'll be able to have some understanding of the technology and how it might be used, distinguish some key differences in how clinicians respond to it and how people receiving palliative care respond, and discuss some possible reasons for these differences and what they might imply. So, bispectral index technology, you may be familiar with it, I don't know. It's used in anesthesia mostly to assess levels of consciousness with EEG data, which is collected by this forehead sensor. So this is one of our patient participants whose pseudonym was Jim, who's kindly modelling the technology for you. So you see there's a forehead sensor and then a little monitor, which is about this size, which sits on the bedside. And it displays a number, not the actual EEG data, but just a number. And just to say, we bought the technology, it wasn't provided to us by the company. So a few studies have looked at its use in palliative care where it may be relevant because, as you know, people may become unconscious, but there's a question about their level of awareness. So that's the uncertainty. So a few studies have looked at whether it might be relevant in palliative care, mostly in Australia, but a few in Europe. And in 2015 to 2020, Marie Curie funded a program in our department which was looking at communication and sedation more generally. And this was part of this, which was a doctoral study. And the study was to trial the use of BIS in a London hospice, but before we actually went to the trial stage, we wanted to understand how acceptable it would be to clinicians and people receiving palliative care, and that's what this study is reporting on. So we use qualitative methodology to explore attitudes before and after the trial. Sorry, I've got a cough. So the data collection, we conducted interviews and focus groups with experienced palliative care clinicians before we trialled the technology. They were focus groups, which I facilitated all of them. Most of them were observed by another author, and a few were observed by 2 other people. So AMK's Anna Maria Kroper, who was the doctoral student at the time. And after the trial, Anna Maria conducted all the individual interviews. And the people receiving palliative care, so patients and also informal carers, family and friends, also participated in focus groups and interviews. So Anna Maria facilitated all the focus groups and I observed them all, and she and I conducted a few individual interviews. And after, she conducted all the individual interviews. And all our participants chose their own pseudonyms. So in some of the data I'll present, there are names, but they're not the real name, they're the name that the participant chose. And as you know what qualitative data research is, but we recorded and transcribed verbatim and then analysed qualitatively. So beforehand, we conducted focus groups and 3 individual interviews with a total of 25 people receiving palliative care. So current patients, current family and friends, and some bereaved family and friends. And most of them were either neutral or positive towards the technology. So the positive perceptions were about potential benefits, that they thought it was acceptable, they didn't see a problem with the technology. So in all the focus groups, we took people the monitor and the strip, and people could play around with it and look at it and see what it was like. Mostly, there were conditional agreements, which are kind of obvious. So as long as it was, everybody was involved in decisions, that it was clinically valuable, depending on the particular patient and what their situation was and so on. And as long as it was always used in addition to usual care, not as a substitute. And then some reservations to do with medicalisation, a few comments about appearance, unreliability, that it could be distressing for family members to see the figure on the monitor, inappropriate for agitated patients. And then we also asked about when and where, and people about length of time, that people were saying as long as necessary, as long as not causing distress, and so on. And mostly thought it would be acceptable everywhere and could see some benefit in a home situation, especially where you have people coming in, professionals coming in only occasionally. And after, there was no real change. So because people were generally open or neutral, and then afterwards they were still generally open or neutral. And I would just comment that we didn't interview any family or friends afterwards, because patients generally took part when they were on their own because they were bored. So there weren't family and friends around to observe the technology being used. So clinicians, we conducted 8 focus groups beforehand, and most again were open or neutral, but some of the clinicians had very significant negative comments, mostly around the potential for physical or emotional harm or hurt for the patients and the loved ones, and also to do with restrictions or limitations for patients or clinicians. And I would just comment here as well that this study, for obvious reasons, we conducted it with conscious patients, but if you actually use the technology in practice, it would be with unconscious patients, but we wanted to understand what patients thought, so they were conscious. So it wasn't a strict reproduction of what actually clinical use, it was an exploration of acceptability. So the point about restrictions or limitations for patients doesn't really apply, because it would be unconscious patients, but it might be limiting for clinicians. So some of the comments, this was probably the strongest response. My gut reaction is, I hate it. So Bridget saw this and it was just like, oh no. This was a more tentative. I would worry a little bit that it might cause more distress, and this is what I was saying about seeing the numbers on the monitor and so on. Another one, I would worry about pressure sores, and another, I think the enduring memory would be that strip across someone's forehead. So some quite strong responses. Most were not like this, but there were some really significant strong responses. And then afterwards, 10 individual interviews, and overall, nothing negative. So it didn't seem to have much effect on the patients, it didn't cause them harm or hurt, didn't restrict people, and was not shocking to view, which is quite important, I think. So I think when I first saw it, it looked a little bit scary. It looked very invasive, but it's not actually. It kind of looked like electric shocks, but you know that it doesn't actually do that. When I first saw it, I thought it would be a burden for the patients, but I discovered that wasn't the case. So remember, even though they were conscious patients, we had kind of trolleys and things. If people needed to go to the loo, they could wheel the monitor, and it's a small monitor. But again, as I say, it wouldn't be used in practice like that. It doesn't really get in our way. And when it's just on the forehead, the patients don't seem to be bothered by it. They don't even know it's there, really. So quite a shift in how the clinicians viewed it afterwards, as opposed to the patients and relatives and friends who were open towards it before and after the trial. And obviously, they're not experts on the technology or on palliative care, so we have to take this on that basis. But they were much more open. Clinicians, as I say, few were very strongly negative, not really on the basis of the technical quality, but about the appearance of the technology. But afterwards, no clinicians expressed any negative views. So one conclusion from this is that clinicians were more protective than may be entirely necessary or appropriate, certainly more so than the patients were. And we know about gatekeeping, and clinicians are protective towards their patients, understandably, but perhaps this was more so. But it was valuable to do this study so that we could actually explore that in detail. And I will note that one study limitation is that, of course, everybody was a volunteer. So they could have been volunteering because they were already more open towards the technology. So we don't know about people who were resistant to technology who didn't even volunteer to take part either before or after. So I just want to thank you all for coming and for inviting me to do this, and of course all the research participants and the co-authors, and Marie Curie for funding us. And we have published 2 papers so far. So this one, the first one on the left, is about usual practice in relation to using sedatives, prescribing sedative medication. And the other one on the right is Anna Maria's paper, first paper from her PhD, which is the before acceptability of patients and relatives. And we have more to come, so do look out for those. Thank you very much.
Can you hear me all right from here? Yeah? Shall I go and stand up there? Okay, can you hear me now? Okay, can people in the audience hear me? Yeah, okay. I thought that was a fascinating session. I hope you agree. What it really reveals is the diversity of research methods. And I would compliment you all because together you've somehow thrown a light on very different research methods. There's a few things I think are really worth picking up at sort of high level. First of all, from Monisha, we had an illumination of new technology, really. Something, I guess, that, you know, we might all begin to see in our own lives, and a consideration of what that might be for patients near the end of life. And we know how difficult it is when people are bedbound and restricted and how much they lose. It also was a really interesting, so I'm really interested in research methods, and I guess you all are because you're in this session. For me, it's a really interesting thing about what's your primary outcome. And I think so often in the literature you can see where the primary outcome wasn't spot on. And I think the longer I've worked in research, the harder I have realised it is to pick your primary outcome. And also to time your primary outcome right. Because obviously there's a bit of longitudinal that one needs in this, but how much time have we got for any longitudinal data in such a population? It's a real challenge. There's also a big issue with measuring quality of life, of course, isn't there? Because so many things impact upon quality of life. And I think obviously it was a good choice to have it as a secondary outcome. But nevertheless, I guess it still raises a big question for me. If we have technology like you described, is that a little bit of added improvement to quality of life for a small number of people? Or is it something that can reach into the quality of life issues for a bigger cohort where they're really losing a component of quality of life? And I think that's a really big question. So I guess this is for the next research steps, isn't it? But, you know, to begin to think, where does this apply? In which sector of our population does this apply? And how does it really impact on quality of life? Because I think one of the things we've all learned over the past few years of the pandemic is the importance for every piece of research just thinking, does this widen the inequities in the people we serve, or does it narrow the inequities? And I think that is a really profound and important question for almost every piece of research that we do. Big question for many of us now. We can't afford to do anything which widens inequities in care at whatever level. But fantastic piece of research, and I loved the mixed methods. You know, I think it's a really great example of how you can use mixed methods to throw light on different aspects, and all of us, I think, are increasingly using mixed methods in some ways. I really liked Nicolas's fantastic example of how, when there are really big variations in practice, we can go to the existing data and look in a very systematic way, a huge retrospective data study, to try and unpick why those variations are there. And I think compliments to you and the team for looking back at a big cohort of patients to really unpick that. The difficulty with retrospective data studies of that kind, and I think you had recognised it really well in your team, is the limitations of what it can tell us. So, you know, it's always going to be prone to bias, and it's never going to give us the answers we hope to reach for, because what it really does, it illuminates where to ask the very discrete questions for the prospective studies. And that was a fantastic example of that, and it was great to see how much the team had recognised that. The other thing that I think in research that I've learned is the importance of marrying up the people on different sides of fences. What I mean by that is that if you marry up the clinical viewpoint and the statistical viewpoint, for example, you can get some really, really interesting answers. And I think one of the things that you were reaching towards in the different survival curves was, actually this is a mixed population. This is a very heterogeneous population. And where are those questions? So you'd got some diagnostic indicators that you were trying to look at, hematological malignancies, how do they all unpick? And actually for me, one of the really important clinical questions in this area is, where are those people actually transfusion dependent? And where is transfusion being used as an added intervention to support something, but they're actually not transfusion dependent? And it seems to me that if you can tease apart those clinical cohorts in some way, which is a challenge, how do you do it? Because it's really a spectrum, isn't it? But there's certainly some people who are very transfusion dependent, and there's others for whom it's really not an issue in terms of dependency of transfusion. And if you could tease them apart, you might actually see some really interesting clinical patterns which will help inform the future work. The other thing I'd love to have seen a little bit more of, but again it's hard, isn't it, with retrospective data, is trying to understand about the adverse effects. And I guess some of the place of death was approaching that, but there's so many other potential adverse effects that we might reflect on. Bella, coming to our third presenter, it was fascinating, wasn't it, to really understand something quite new. And I think probably many of us have not experienced that kind of technology. And I suppose what I really love about that is, again, this use of qualitative, good qualitative research before and after a trial. And I think more and more we've got to work at judicious use of mixed methods to really help shine the spotlight in different places to understand what's going on. And that was a lovely example of that. We didn't hear about the trial and the quant side, but I guess that's for another day or for reading some other papers. Potentially very illuminatory for a new area. I guess I would have loved to understand a bit more, perhaps it wasn't within scope, actually what this was really offering. What were the benefits of this particular technology? technology. And did people begin to see some of those benefits in the post phase? Because that would have been interesting. I'm going to be posting a few questions. You can either post them on the app or you can ask people afterwards. But there's lots of questions there, isn't there, about where has this gone in the subsequent 3 years, and where has it taken us, and maybe a little bit more too about safety. I think in quantitative trials, we always have to be thinking of the safety aspects of that as well as the positive benefits. And I think we sometimes forget to pay enough attention to the safety and adverse aspects. So for me, this was a great gallop through different research approaches, and especially the use of mixed methods, and especially thinking of the limitations of what any particular method or approach offers you. But I think huge compliments to them all, because it represents a wonderful amount of work. Thank you.
So thank you very much to all of our presenters and to Dr. Murtagh for your reflections. I think we had an incredibly important session this morning, so we thank you for starting the day off so well. I just wanted to remind anyone in the room who would require this, the plenary at 9 o'clock is going to be in French. So if you do need translation headsets, please take the opportunity to pick them up in the back. It's going to be much easier for you than going to the main lobby. So that's one of the benefits of getting here early, you see. Thank you.